Respected audience, Assalamu alaikum. I am Professor Shamsud-Jaman, Professor of Pathology. I welcome all in today's 9th lecture on hematology. Today, day 4 of leukemia. Previously, I have told you about the acute lymphoblastic leukemia and acute myeloid leukemia. Today, come to chronic myeloid leukemia. CML, or it is also called chronic granulocytic leukemia, CGL. If anybody suffers from chronic myeloid leukemia or chronic granulocytic leukemia, what may be the clinical presentations? Now come to clinical presentations of patients suffering from leukemia. Dear audience, you know acute leukemia usually occurs in childhood, but chronic myeloid leukemia usually occurs at middle age. Usually middle age, and there is anemia, so symptoms of anemia, like pallor, fatigue, effort intolerance, palpitation. Briefly, these are the symptoms of anemia. Besides this, there is splenomegaly, hepatomegaly, and this CML may be diagnosed or discovered accidentally on routine blood examination. Accidental diagnosis or accidental discovery on routine blood examination. So these are the clinical presentations of chronic myeloid leukemia. So if anybody of middle age or elderly age with symptoms of anemia, splenomegaly, hepatomegaly, we may suspect it could be a case of chronic myeloid leukemia. Besides this, the patient may suffer from frequent fever also. So how chronic myeloid leukemia or chronic granulocytic leukemia is diagnosed in laboratory? That is, now come to laboratory diagnosis of CML. How to diagnose in laboratory? We have to do blood examination, bone marrow examination, myeloperoxidase test, then chromosomal study, then flow cytometry, cytochemistry. So in laboratory we can diagnose a case of CML by examining blood, bone marrow, myeloperoxidase test, chromosomal story or karyotyping, flow cytometry, cytochemistry. Now come to blood examination first. We have to do first hemoglobin. The percentage of hemoglobin reduced, as it is a case of leukemia. Patient suffers from anemia there, so hemoglobin reduced. Then ESR, it is elevated. We have to do TLC, total leukocyte count. You know, normal count is 4,000 to 11,000 per cubic millimeter blood. In case of leukemia, it is usually leukocytosis. So we'll get leukocytosis, and the count is usually more than 1 lakh per cubic millimeter of blood. Leukocytosis. And usually more than 1 lakh per cubic millimeter of blood. Then we have to do differential leukocyte count, DLC, differential leukocyte count. Here we will get most of the cells of WBC series are myelocyte and metamyelocyte. Most of the cells are myelocyte and metamyelocyte. Along with myelocyte and metamyelocyte, increased number of basophil. Dear audience, you know basophil usually in our blood it is less than 1%, but if it is a case of CML, the percentage of basophil in CML is 2 to 10% or more than 10%. So basophil in case of DLC, basophil is 2 to 10% or more. So in DLC we will get most of the cells are myelocyte and metamyelocyte. So myelocyte like this is the nucleus, and the cytoplasm contains granules. So these are the myelocytes, and this is myelocyte, and another cell will get metamyelocyte like this. This is the nucleus, and these are the basophils. So this is metamyelocyte. And along with this increased number of myelocyte and metamyelocyte, you will get basophil. You know, if it is basophil, this is the nucleus like this, and this is the basophils. So this is the DLC. Now come to peripheral blood film. PVF. We have to first search for the RBC series. The cells show hypochromia. Cells of RBC series show hypochromia. Hypochromia with occasional nucleated red cell. Dear audience, you know leukemia is the blood cancer of hematopoietic stem cell. So if this is the medullary cavity and this is the bone, and this medullary cavity contains bone marrow. If there is cancer of the hematopoietic stem cell bone marrow, the leukemic cells come in the peripheral blood, and along with this the patient suffers from anemia. As the patient suffers from anemia, there is stimulation of the bone marrow to produce RBC rapidly. Due to rapid production of RBC within the marrow in case of anemia in leukemia, there will be some production of nucleated cell that are produced in the bone marrow come along with the mature RBC in the blood. So there is a few number of nucleated cells in the peripheral blood. It is due to rapid production of RBC in marrow in case of leukemia. Now come to WBC series in peripheral blood. WBC series, cells show leukocytosis with most of the cells are myelocyte and metamyelocyte. Along with increased number of myelocyte and metamyelocyte, there is increased number of basophils. Along with this increased number of basophils. So this is the WBC series of CML. Then platelet seen adequate in number. So the peripheral blood film of CML RBC series show hypochromia with occasional nucleated cells. W series cells show leukocytosis with most of the cells are myelocytes and metamyelocytes, and increased number of basophils. Platelets seen adequate in number. Then we have to do reticulocyte count. Dear audience, you know normal reticulocyte count is 0 to 2%. You know reticulocyte is the stage of maturation of RBC. Before it, the just a bit ahead the mature RBC. The normal count is 0 to 2%. It will be increased. Why increased? As there is rapid production due to anemia, due to rapid production, so there is immature RBC like nucleated cell and like reticulocyte count in peripheral blood. Now come to bone marrow examination. Now come to bone marrow. Now come to bone marrow examination for diagnosis of chronic myeloid leukemia. Dear audience, you know leukemia is a blood cancer and it is the cancer of hematopoietic stem cell. So marrow will be hypercellular. So marrow is hypercellular with increased myeloid erythroid ratio. Dear audience, as it is a cancer of myeloid series, so myelopoiesis, myeloid series cells is increased. So there is increased myeloid erythroid ratio. Then erythropoiesis is depressed but normoblastic. Dear audience, you know if it is bone and this is medullary cavity containing bone marrow, as it is a leukemia of myeloid series, so RBC series or erythropoiesis is depressed. So erythropoiesis is depressed but it is normoblastic. Then granulopoiesis is hyperactive. As it is chronic granulocytic leukemia, so granulopoiesis is hyperactive with most of the cells are myelocyte and metamyelocyte. Dear audience, you know in normal bone marrow granulopoiesis is active and with all stages of maturation, there is myeloblast, proportionately promyelocyte, proportionately metamyelocyte, myelocyte, etc. But as it is a blood cancer, it is chronic granulocytic leukemia, so granulopoiesis is hyperactive and there is no wall stage of maturation proportionately, but most of the cells are myelocyte and metamyelocyte. Then megakaryocyte seen adequate in number, and megakaryocyte is adequate in number. No parasite found, no parasite found in the marrow examined. So marrow is hypercellular as it is blood cancer, as it is cancer of hematopoietic stem cells, so hypercellular marrow. As it is chronic glioma cell leukemia, myeloid series cancer, so increased myeloid erythroid ratio. Erythropoiesis is depressed but normoblastic erythropoiesis. Granulopoiesis is hyperactive with most of the cells are myelocyte and metamyelocyte. Megakaryocyte seen adequate, no parasite found in the marrow examined. Now come to myeloperoxidase test. Dear audience, as it is a case of chronic myeloid leukemia, we'll get most of the cells are myelocyte and metamyelocyte. Along with, we can get a few number of myeloblasts also. So if we do myeloperoxidase test for chronic myeloid leukemia, the myeloblasts that are found along with the most of the number of myelocyte and metamyelocyte will be peroxidase positive. So in case of CML, the myeloblast found a few number is peroxidase positive. Then we have to do cytochemistry. We do cytochemistry to differentiate the cells. We do it to differentiate cells of myeloid series, monocyte series, and lymphoid series. Then we have to do chromosomal study. That audience, in karyotyping or in chromosomal study, we search for the Philadelphia chromosome. In most of the cases of CML, we can get Philadelphia chromosome. So in most of the cases of CML, we get Philadelphia chromosome. Dear audience, I have told you what is Philadelphia chromosome. If this is 9th chromosome and this is short arm, and if this is 22nd chromosome, centromere, and this is short arm, this is 22nd chromosome. If translocation occurs between these two, after translocation, what will get is some portion of this and some portion of this short arm is exchanged, and this is called translocation. After translocation between the 9th and 22nd chromosome, after translocation, this 22nd chromosome is called Philadelphia chromosome. So after translocation between 9th and 22nd chromosome, the 22nd is called Philadelphia chromosome. it is called Philadelphia chromosome. Why it is called Philadelphia? It is termed according to the name of city Philadelphia. Now come to flow cytometry. Dear audience, we do flow cytometry to diagnose leukemia. It is a laboratory method. This method is used. It is used number one, to detect a specific cell. It is used to detect a specific cell. It is used to identify a specific cell. It is used to count a specific cell. It is used to obtain a special component. It is used to obtain a special component of cell. So these purposes of use of flow cytometry. All these informations regarding cell is based on. So all above informations regarding the cell is based on. So all the informations regarding the cell is based on two things. One is physical characteristics of cell. So this information based on physical characteristics of cell, and it is also based on presence of antigen on cell membrane, or within the cell. So the informations that you get by using flow cytometry is based on the physical characteristics of cell, and it also based on presence of antigen on cell membrane or within the cell. What is done in flow cytometry? Cells are stained. First the cells are stained. After staining, cells are allowed to pass as a lamellar. So after staining, the cells are first or allowed to pass as a lamellar flow through a laser beam. So after staining, the cells are allowed to pass as a lamellar flow through a laser beam. Then the light scatter. Is measured. Is it measured with fluorescence impedance. What is done? First these cells are stained, then cells are allowed to pass as a lamellar flow through a laser beam, and the light scatter is measured with fluorescence impedance. This is the flow cytometry, and this is all about the laboratory diagnosis of chronic myeloid leukemia, that is chronic granulocytic leukemia. Now come to, if anybody suffers from chronic myeloid leukemia for long time, for many years, a person is suffering from chronic myeloid leukemia for many years, patient may suffer from a crisis that is called blast crisis or blastic transformation. Now come to blast crisis or blastic transformation. Blastic transformation. So anybody suffering from chronic myeloid leukemia for long time, he or she may suffer from blast crisis or blastic transformation. Now come to what is blastic transformation, what is blastic transformation or blast crisis. Patient with chronic myeloid leukemia, patient with chronic myeloid leukemia may suffer from progressively increasing splenomegaly with increased myeloblast and thrombocytopenia. Is called blast crisis or blastic transformation. Respected audience, you know patient with CML may come to you with splenomegaly, you know, hepatomegaly. So anybody suffering from chronic myeloid leukemia for a long time, he or she may develop blast crisis or blastic transformation. What is this? Patient with chronic myeloid leukemia suffer from progressively increasing splenomegaly. Number one, with increased myeloblast and thrombocytopenia. You know, in CML, in chronic myeloid leukemia, there is a few number of myeloblast, but most of the cells are myelocyte and metamyelocyte. If there is blast crisis, myelocyte number is decreased, but myeloblast is increased, and there is thrombocytopenia. And this increased myeloblast and thrombocytopenia, patient may behave like acute leukemia. So you know, in chronic myeloid leukemia, there is no increased number of myeloblast, but there is most of the cells are myelocyte and metamyelocyte, and there is no thrombocytopenia. If the patient suffering from CML develops increased myeloblast and thrombocytopenia, it looks like acute leukemia. Then it looks like acute leukemia, because in acute myeloblast leukemia, most of the cells are myeloblast and there is thrombocytopenia. So patients suffering from blast crisis behave like the acute myeloblastic leukemia. So if anybody suffers from blast crisis or blastic transformation in CML, what may be the presentations? So presentations or patients with blastic transformation may come to you. Presentation of blast crisis. So if anybody suffers from blast crisis, what will be the presentations? The presentations like infection. As most of the cells are myeloblast, there is more chance of infection. So due to infection, patient may come to you with frequent fever. Then hemorrhage. Hemorrhage like nasal bleeding, like gum bleeding, like rectal bleeding, etc. and internal hemorrhage also. This hemorrhagic disorder in blast crisis is due to thrombocytopenia. due to thrombocytopenia, there is bleeding manifestations. And patient may develop lymphadenopathy. Lymphadenopathy. So these are the presentations, common presentations of patient with chronic myeloid leukemia suffering from blast crisis. And patient may come to you with besides infection, hemorrhage and lymphadenopathy, patient may come to you with chloroma. So presentation is infection, frequent fever, hemorrhage, lymphadenopathy and chloroma. Now come to chloroma. Now come to what is chloroma. Dear audience, chloroma is a tumor-like mass due to subperiosteal deposition of leukemic cell. So what is this? A tumor-like mass. A tumor-like mass due to subperiosteal deposition of leukemic cells. Leukemic cells is called chloroma. So chloroma is a tumor-like mass due to subperiosteal deposition of leukemic cells. Now come to common sites of chloroma. Common sites of chloroma. Common sites of chloroma. It may be found in skull bones usually. Skull bones usually. Besides this, you can get in sternum and you can also get in ribs. So whatever may be the site of chloroma, it is nothing but tumor-like mass due to subperiosteal deposition of leukemic cells. So if you suppose this is a rib, if this is a rib like this, and this is the periosteum, if this is the periosteum, so there will be subperiosteal collections of leukemic cells giving rise to a mass, and this mass is known as chloroma. This is chloroma. So where chloroma is found, what are the conditions or what are the situations we can get chloroma? So chloroma is found in number 1, acute myeloid leukemia. It is found in blast crisis of CML. So if there is blast crisis of CML or anybody suffers from acute myeloid leukemia, we can get chloroma. So this is all about the chloroma, and this is all about the chronic granulocytic leukemia, that is chronic myeloid leukemia, and blast transformation or blastic transformation and blast crisis of chronic myeloid leukemia. Today after this, thanks all.